Hello everyone. Welcome back to the series of lectures in neurology. In continuation with our disorders in the spinal cord, we will be discussing today about multiple sclerosis and NMO spectrum disorders. So what is multiple sclerosis? Multiple sclerosis is basically an autoimmune disorder. So it is an autoimmune disorder where there is destruction of the myelin sheath. Okay, so it's an autoimmune disorder which is characterized by destruction of the myelin sheath leading to demyelination. So in MS, you have an autoimmune destruction of the myelin sheath resulting in demyelination, and it predominantly affects the oligodendrocytes. Which are your supporting cells which are present in the central nervous system, right? So there is demyelination, which is your most important underlying feature of multiple sclerosis. So let us understand the epidemiology and the risk factors for MS. MS is more common in the age group of 20 to 40 years, and it is more common in females, and it is more common in the temperate region. Okay, what are the risk factors? The established risk factors for MS includes vitamin D deficiency, predominantly vitamin D deficiency, history of EBV infections, which is your Epstein-Barr virus, and cigarette smoking. Okay, but we have really not found a causal relationship, but it has been found that these are some of the risk factors for developing multiple sclerosis. We should also take into consideration what are the genetics. So, whites are at a higher risk of MS, and MS has a polygenic inheritance. Predominantly HLA-DRB1 and HLA-DR15 are the predominant HLAs which are involved in your multiple sclerosis. Okay, so that's about your epidemiology and risk factors. Now let us understand the pathogenesis of multiple sclerosis. So the hallmark feature or the most characteristic feature, underlying feature of MS is demyelination. Like I told you, there is an autoimmune destruction of the myelin sheath. So what are the various mechanisms by which there is an autoimmune destruction, right? So there can be T cell mediated and B cell mediated autoimmunity which is found in these patients due to unknown reasons, maybe because of your genetic factors or your environmental factors. These cause a predisposition for demyelination. Okay, so the trigger is often unknown. Many a times it could be viral or it can be in a genetically predisposed individual. So there can be development of both B cell and T cell immunity. When we talk about humoral autoimmunity, the antibodies which are produced are your myelin specific antibodies, which is your MOG, which is your myelin oligodendrocyte glial protein. Okay, so there are antibodies which are produced against your myelin oligodendrocyte glial protein, which are myelin specific antibodies. These are in fact locally synthesized antibodies. They are synthesized within the CSF, right? They are synthesized within the CSF, and that is the reason why in MS, when you do an oligoclonal band, when you do an OCB testing, it is called as an oligoclonal band testing. It is this which you find. You find the antibodies in the CSF. These are oligoclonal in nature and they are myelin specific antibodies which are found. So this is the basis of humoral autoimmunity in MS. Okay, then there can be autoreactive T cells as well. Predominantly by it is a CD8 plus mediated toxicity. So it is your CD8 positive T cells which are basically your toxic C cells which go and damage your myelin. So you have a autoreactive T cells as well, and these are against your MBP, which is your myelin, which is called as myelin basic protein. So you have autoreactive T cells against your myelin basic protein, which is because of CD8 positive T cells. So if you see this is an MS plaque. So at the periphery of the MS plaque, whenever you do, let us say in olden days when we were doing a brain biopsy and observing under the microscope, the periphery of the MS plaque is characterized by the CD8 positive T cells, indicating that a T cell mediated autoimmunity also plays a role. Okay, so this is about your humoral autoimmunity and T-cell autoimmunity, right? Followed by your humoral and T-cell autoimmunity, what happens? There is another important mechanism which is responsible for the various changes in MS, that is your blood-brain barrier disruption. So the blood-brain barrier plays a very important role in ensuring that there is no external damage to the brain, right? So these T cells and B cells can cross the blood-brain barrier and they cause damage within the CNS, right? So this is characterized by periventricular cuffing of T cells and macrophages. If you see it under your histopathological examination, around the ventricles you will see cuffing of the T cells and B cells, right? And they are predominantly again CD8 positive T cells which are responsible for the degeneration of the myelin. So whenever the blood-brain barrier is damaged, there can be leakage of protein into the CSF as well. And very importantly, under your histopath, there is no evidence of vasculitis. So the vessels are normal, but because of locally synthesized antibodies as well as T-cell mediated immunity, there is a damage to the blood-brain barrier, and these cells cause damage to the CNS as well, resulting in demyelination. The myelin is removed from the axons of the neurons. So that is about your pathogenesis of demyelination. How does demyelination happen and what is the effect of demyelination? Then there can be attempts of remyelination. So every time there is a demyelination, there can be attempts of demyelination by the oligodendrocyte. This results in what we call as shadow plaques. Okay. Apart from that, the astrocytes also get abnormally stimulated. There can be astrocyte proliferation which results in gliosis, and finally all of this results in your neurodegeneration. So finally, as the myelin is lost, there is gliosis, there is abnormal proliferation of astrocyte cells and demyelination, remyelination happening again and again, cycles of demyelination, remyelination. There is damage to the neurons. There is neurodegeneration. Okay, so this is your entire pathogenesis of MS. And finally, we should also understand another important concept of conduction block. So this demyelination, how does it impact your neurotransmission? So we know that the axons are covered by myelin sheath and there are small gaps which are present in between this, which is your nodes of Ranvier. This is the nodes of Ranvier. And we know that myelinated neurons carry the impulses at a much faster rate when compared to non-myelinated neurons, right? How is that happening? That is because the impulses basically skip through the nodes of Ranvier, and this is what we call as saltatory conduction, right? So the impulses basically skip through the nodes of Ranvier, and this is what we call as saltatory conduction. So whenever there is demyelination, then the saltatory conduction gets lost. The saltatory conduction gets lost and there can be a block in the flow of the transport. There can be a block to the neurotransmission. There can be a block to the neurotransmission, and this is what we call as conduction block. There can be a block to the neurotransmission because of your demyelination, and this is what we call as a conduction block, which is a classical feature of demyelination. Okay, so finally there is a conduction block, there is slowing down of impulses, and there is neurodegeneration. Clear? So this is about the pathogenesis of MS. Okay, so we have both humoral and T-cell mediated immunity, predominantly humoral mediated autoimmunity, which is responsible for your MS. Let us understand the clinical features of MS one by one. Okay, so most common of the clinical features is the presence of sensory symptoms. Okay, so now demyelination happens in predominantly your CNS. It can happen in your PNS as well. Okay, but predominantly this is your central nervous system, brain and spinal cord. So whenever there is a demyelination, there is damage to the cells of the spinal cord. There can be damage to the nerves arising from the spinal cord as well. So because of damage to the spinal cord and the tracts, there can be damage to the spinothalamic tract, which can result in sensory abnormalities. So they can present with paresthesias, they can present with tingling, and finally in later stages there can be loss of sensation as well. So you can have paresthesias, tingling and loss of sensations as well. Also, the most common nerve that is involved is your optic nerve. The optic nerve is also encased by the myelin. So, damage to this myelin sheath there can result in optic neuritis, which is again seen in up to 36% of the individuals with multiple sclerosis. Right? So, how does optic neuritis present? Optic neuritis presents as predominantly color desaturation. So, the first sign is that they have difficulty in appreciating color. Right? So, there can be color desaturation, there can be dimness, there is a decreased appreciation of color, and there is a decrease in the visual acuity as well. There can be periorbital pain, and finally in the later stages there can be optic atrophy. And most often in MS, remember that it is unilateral or monoocular optic neuritis at onset. It does not have bilateral optic neuritis. It usually has a unilateral optic neuritis. So, optic neuritis, sensory symptoms, and very importantly, you can have weakness. Okay, because this is involving the spinal cord. If it involves the spinal cord, you can have weakness, and the weakness is mainly a UMN pattern of weakness. So, you can have spastic paraplegia or spastic paraparesis. Right? In 15% of the individuals, you can have diplopia. Diplopia means double vision. Okay, why do you have diplopia? There are multiple reasons for diplopia in your MS patient. So, most importantly, there can be demyelination at your brainstem. There can be demyelination in your brainstem. When we had spoken about brainstem syndromes, what are the 4 M structures which are present medially? One of it, most importantly, is your MLF, which is your medial longitudinal fasciculus, which is responsible for your horizontal gaze. Right? So, when there is damage or demyelination of the MLF, you can have internuclear ophthalmoplegia. Internuclear ophthalmoplegia. So, INO or internuclear ophthalmoplegia is your one of the most common causes for diplopia or your double vision in MS. Then you can have 6th cranial nerve involvement. Bilateral 6th cranial nerve involvement can also be there. Then what is Web-ENO? Web-ENO is wall-eyed bilateral INO. So, there can be bilateral INO as well, and this is how the eyes will look. They point towards the wall. So, wall-eyed bilateral INO. And further demyelination can involve both the PPRF and the MLF. You can understand all of this in your brainstem syndromes chapter. Okay, PPRF is paramedian pontine reticular formation, which is again controlling your ipsilateral abducent nerve nucleus. Okay, so involvement of the PPRF plus MLF can result in something called as 1.5 syndrome, where one eye cannot move to either sides and the other eye is affected in terms of its medial rectus. Okay, in terms of its medial rectus. Fine. Then, so the other type of nystagmus that you can get is called as an acquired pendular nystagmus. So, the most common cause for an acquired pendular nystagmus is your multiple sclerosis, where you have a nystagmus in the form of a pendular nystagmus. So, what happens is that there is a nystagmus in which the fast component is towards, let us say, the right side, and then when the eye moves towards the left side in the nystagmus, it shoots over, moves like a pendulum and comes back to the center. And this is what we call as a pendulum-like nystagmus or an acquired pendular nystagmus. So, this is about the various eye manifestations in multiple sclerosis. So, you can have weakness, you can have subjective sensory symptoms, you can have optic neuritis, you can have INO. Okay. To understand about INO and understand about 1.5 syndrome, you will have to look at the chapter on brainstem syndromes, where I have spoken about MLF lesions. Alright, fine. Now, ataxia. Ataxia can be seen in 11% of the individuals because of demyelination in the cerebellum, and vertigo can also be there because of demyelination in the brainstem, involvement of the vestibular nucleus. Another very important symptom which is very characteristic to multiple sclerosis itself is the presence of something called as paroxysmal symptoms. So what is paroxysmal symptoms? These are short or brief symptoms which appear rapidly and disappear rapidly as well. So they can be similar to a TIA, they can be confused with a TIA. Okay, so this is your paroxysmal symptoms, which is very, very characteristic to MS. So these paroxysmal symptoms can last from 10 seconds to up to 2 minutes. Okay, and you can have nearly 5 to 40 episodes per day. Right? So why is it called paroxysmal? Because what are the differential diagnosis for this? This is a TIA or it can be a seizure. So you have transient neurological symptoms which appear for few seconds rapidly and may disappear. So that is why you do an EEG. EEG shows no changes in your paroxysmal symptoms, and it is usually precipitated by hyperventilation or it can be precipitated by movement. Okay, so paroxysmal symptoms is very, very characteristic of MS. So what are the paroxysmal symptoms? The first is your Lermiti's sign. The first paroxysmal symptom is the presence of this Lermiti's sign. Okay, so what is this Lermiti's sign? This is a brief shock-like sensation. Okay, so this is a brief shock-like sensation which runs down the neck, on sudden flexion of the neck. On sudden movement of the neck, you can have a brief shock-like sensation which is running down posteriorly. This is called as a Lermiti's sign, which is one of the paroxysmal symptoms. You can have paroxysmal tonic seizures. That is why this criteria of no ECG changes is very, very important. You can have paroxysmal tonic seizures, you can have paroxysmal dysarthria, ataxia, right? All of these can be seen. Then, what are the other symptoms which can be seen in your multiple sclerosis? There can be demyelination at the level of exit or entry of the nerve root in the central nervous system, right? When it enters into a foramen or when it arises from somewhere. That is the reason why you can have trigeminal neuralgia. There can be demyelination at the level of origin of the trigeminal nerve. So you can have trigeminal neuralgia, you can have glossopharyngeal neuralgia. So trigeminal neuralgia will present with severe episodes of excruciating facial pain, right? Sudden facial pain. Glossopharyngeal neuralgia, then hemifacial spasm can also happen because of demyelination of the seventh nerve as it arises from the pons. Then facial myokainia, right? Because of this excessive irritability of the facial nerve, you can have minimal flickering movement of the facial muscles, which is called as facial myokainia. Then another symptom that you can have is called as Uthoff symptom, where all these paroxysmal symptoms, are worsened on heat exposure. So many of the MS patients will have symptoms which worsen after taking a hot bath. They have symptoms which worsen after taking a hot shower, mainly because of this Uthoff phenomenon. Alright, and bladder dysfunction, yes, because MS mainly affects the spinal cord. So spinal cord is where the nerve roots supply the bladder. So what type of a bladder weakness you will get? You will get a type of UMN or spastic bladder. You can get UMN or spastic bladder. Spastic bladder is a small hypercontractile bladder. So every time the urine fills in, it is spastic, it contracts, leaves out the urine, and this type of incontinence is called as an urge incontinence. Okay. So in an acute episode of MS, because the patient will be in spinal shock, I told you any acute episode of spinal cord disease is, be it MS, be it transverse myelitis, be it any trauma, the spinal cord will be in spinal shock. So in spinal shock, you will have flaccid paraparesis, with a LMN type of bladder, which is a large bladder, which is unable to contract, and hence you will have overflow incontinence. But in the later stages, then as the spasticity progresses, you will have a spastic bladder or a small UMN bladder, which is characterized by urge incontinence. They have a lot of urgency because the bladder keeps on contracting. They want to pass urine urgently. Okay, and there can be retrosar muscle hyperreflexia. Okay, so that's about the bladder dysfunction. Similarly, you can have constipation, you can have sexual dysfunction as well, predominantly because if the autonomic supply from the spinal cord is affected. More than 90% of the patients can have some non-specific fatigue and cognitive dysfunction can be there, but most of the time your cognitive capabilities are not impaired. Minor cognitive impairment can be present, what we call as MCI. Okay. So this is about the various clinical features of multiple sclerosis. Okay, please do remember your paroxysmal symptoms, Utof's phenomenon, and your predominantly UMN features which are seen in MS, and the optic neuritis of MS is unilateral most often. And INO, if it is present, never forget to evaluate for your demyelination such as multiple sclerosis in a case of internuclear ophthalmoplegia. Now that we've understood the clinical features, let us understand the different types of MS. So the most common type which is seen in 90% of the individuals with multiple sclerosis is something called as RRMS, which is a relapsing remitting MS. This is a RRMS or a relapsing remitting multiple sclerosis, which means that there is a phase where they have an attack, and in between the attack phase they are absolutely normal. So there is no progression of disease. There is no progression of disease between two attacks. Okay. So in an RRMS, which is seen in 90% of the individuals with MS, there is no progression of disease in between two attacks. 10% of the individuals have something called as secondary progressive MS. There is an attack and then they have a relapse, and in the second relapse onwards their symptoms and disease keeps on progressing. A very rare percentage and 3% of the individuals have a primary progressive MS or a PPMS, where with the first attack itself the disease continues to progress. Okay. So this is about the various subtypes RRMS, PPMS and your secondary progressive MS. Now let us understand the diagnostic criteria for multiple sclerosis. Let us understand the diagnostic criteria for multiple sclerosis. So diagnostic criteria for multiple sclerosis includes that there are 2 or more attacks and there is evidence of 2 or more lesions in your imaging. Right? 2 attacks, 2 lesions. Then you do not require any additional data for diagnosis. This is definitely a multiple sclerosis. Okay. The evidence on the MRI should be suggestive of MS, right? So 2 attacks, 2 lesions on your imaging, it is MS. Now, there have been more than equal to 2 attacks. There have been more than equal to 2 attacks. But in your imaging, you have only 1 lesion. In your imaging, you have only 1 lesion, right? Then how will you diagnose your MS? How will you confirm that there is MS? Then you have to show the evidence of dissemination in space, which means that you have to show that there is evidence of disease progression in your imaging. So it is demonstrated by more than 1 T2 lesion on MRI or at least 2 out of 4 MS typical regions in the CNS, which is periventricular, juxtacortical, infratentorial or spinal cord, right? So there are 4 typical regions in the brain where imaging abnormalities of suggestive of MS can be seen. In the periventricular and juxtacortical regions, in the infratentorial regions of the brain and spinal cord. Okay, so if you have more than 2 attacks and only 1 imaging feature, then you have to wait. That is why we call as additional data needed for MS diagnosis. You have to wait for the dissemination in space, which is demonstrated by another lesion. So if another lesion, when it presents, then you can diagnose it as MS. Right? So you await for another clinical attack implicating a different CNS site. Okay? So it can either be this or you have to show for dissemination in space. So dissemination in space means that there is objective imaging evidence of MS in the MRI. Right? So more than 2 attacks but only 1 imaging finding, wait for dissemination in space. Now 1 attack, 2 or more lesions are there. Okay, so you had only 1 attack. There was only 1 episode of paraparesis, but in the MRI you are already finding 2 or more lesions. Then will you call it MS? No, you have to wait for dissemination in time. That means you have to wait for another clinical attack to definitely call it MS. So simultaneous presence of asymptomatic lesions at any time, or a new lesion irrespective of its timing reference to a baseline, or await a second clinical attack. This is what we call as dissemination in time. Okay, fine. Now, if there is one attack and only one lesion, then you require a lot of other characteristics. So, what are those characteristics? You will have to show for evidence of both dissemination in time and space. You will have to wait for another attack and another lesion to definitely call it MS. Okay, fine. Then PPMS. What is the meaning of primary progressive MS? 1 year of disease progression plus evidence of lesions on the MRI and positive CSF oligoclonal bands or elevated IgG index. Okay, so presence of, how do you call it, PPMS. So there is evidence of disease progression over 1 year plus what happens? There is evidence of dissemination in space and dissemination in time and presence of positive CSF findings, then you call it a PPMS. So primary progressive MS shows evidence of disease progression over 1 year. Okay, so this is about the different diagnostic criteria for MS. Okay, so we have 2 attacks, 2 image findings, that is great. But if there is 1 attack and 2 lesions, then you will have to wait for dissemination in time. 2 attacks, 1 lesion, wait for dissemination in space. And if primary progressive MS, how do you define it? That we have already looked at, right? So this is the basic concept about the diagnosis of multiple sclerosis. Let us look at some of the MRI images, right? So these are the characteristic areas where you find evidence of demyelination. So this is your juxtacortical areas. This is what we call as your periventricular. You can see that there are flare or T2 hyperintensities in the periventricular regions, okay, which are called as finger-like lesions called Dawson's fingers. This is your finger-like lesion that we call as Dawson's fingers, right? Can you see evidence of demyelination within the spinal cord? And this is your post-gadolinium contrast enhancement, which shows areas of enhancement like this, indicating injury to blood-brain barrier. So there is damage to your blood-brain barrier. So this is about how demyelination looks or MS lesions looks on the MRI. Then the next, how do we move on to the diagnosis? So how do you diagnose your multiple sclerosis? Not just about your diagnostic criteria, but on your CSF. So in your CSF findings, what you find is a characteristic mononuclear pleocytosis, right? You find cells within the CSF, but they are predominantly mononuclear in nature. Then you can find evidence of synthesis of intrathecal IgG. You can find evidence of synthesis of intrathecal IgG. The next test that we do is something called as CSF OCB, is oligoclonal bands. Okay, so what is the use of the CSF oligoclonal bands? So we had discussed in your pathogenesis of MS that when there is a B cell or a humoral immunity, right? So there are antibodies which are oligoclonally produced, and the evidence of that can be brought about by taking your CSF oligoclonal bands. So they are detecting nothing but your antibodies which are produced against the myelin. Okay, fine. So in more than 90% of the individuals, your CSF oligoclonal bands are positive. When it comes to the pleocytosis, usually the cell count is more than 5 cells and it is predominantly a mononuclear infiltrate. When will you say that it is less likely to be MS? So when is it not MS? Right, if the cells are more than 75, right, so if the cells are more than 75 and you have a neutrophil infiltration into the CSF, cells are more than 75, you have a neutrophil infiltration into the CSF and a protein is more than 1 gram per deciliter, then you have to consider alternate diagnosis other than multiple sclerosis. Fine, so this is about the CSF findings. What are the differential diagnoses for multiple sclerosis? This includes your NMO spectrum disorder that we will be discussing, acute disseminated encephalomyelitis, ADEM, then presence of other autoimmune disorders like sarcoidosis, then AVM. How does AVM mimic MS? Because on imaging it is similar to MS. On imaging it is similar to MS, and this also causes paraparesis. MS is a non-compressive myelopathy, AVM is a compressive myelopathy, and if you look closely in your lesions, you can see the presence of flow voids in an AV malformation. You can see the presence of flow voids, CSF flow voids in the AV malformation. Then CNS lymphomas, syphilis, Lyme's, HIV, all of these non-compressive myelopathies are a differential diagnosis for multiple sclerosis. Okay, so clear till here? We have looked at the clinical features, we have looked at the diagnostic criteria, and we have looked at the CSF findings in multiple sclerosis. Now let us move on to the treatment of MS. So how do you treat MS? Now let us move on to the treatment of MS. So in an acute attack, how are they going to present? They are going to present with transverse myelitis. So how does a transverse myelitis present? It presents with complete, it's similar to your complete transection of spinal cord because the entire spinal cord is involved. So it has a definitive spinal level or a sensory level below which there is paraplegia, complete loss of sensation. There is paraplegia and complete loss of sensation, and there is urinary incontinence. Okay, so the power is literally zero. They are paraplegia, complete loss of sensation, urinary incontinence. So in an acute attack of MS, when there is transverse myelitis, you give IV methylprednisolone. IV MP is methylprednisolone. Okay, this is given at a high dose of 1 gram per day for 3 to 5 days. Right, so you give high dose steroid 1 gram per day for 3 to 5 days, followed by oral steroids at a dose of 1 mg per kg per day, and you give it for 2 weeks and then taper and stop. Okay, so acute attack of multiple sclerosis, give high dose steroids methylprednisolone IV for 3 to 5 days, followed by oral steroids 1 mg per kg and taper and stop. What are the disease modifying agents which are used in the management of multiple sclerosis? So first we will talk about RRMS, which is the most common type of MS, which is your RRMS. So in RRMS, you have a highly effective drugs and a moderately effective drugs. The highly effective drugs are your anti-CD20, which is your ocrelizumab. Then we have your alpha-4 beta-1 integrin inhibitor, which is natalizumab, anti-CD52 inhibitors, alemtuzumab and mitoxantrone. Moderately effective drugs are your sphingosine 1-phosphate 1 and 3 modulators, which is fingolimod or siponimod, dimethylfuramate, glatiramer acetate, interferon beta, teriflunomide. Teriflunomide is similar to the drug leflunomide, which is used in the management of rheumatoid arthritis, cladribine. So this is basically the list of drugs which are used in the treatment of MS in your long-term management. Let us look at each of the drugs one by one. So ocrelizumab. What is ocrelizumab? It is anti-CD20, similar to your rituximab, right? Similar to your rituximab. In fact, the other drugs which are acting the same action is your ofatumumab and your rituximab, right? Ocrelizumab is in fact the most effective drug which is used in the management of RRMS. Okay, so this is given as a dose of IV and it is given every 24 weeks 600 mg dose. Then ofatumumab is given as a SC 20 mg dose on days 1, 7 and 14, and these two drugs in fact have a 95% reduction rate in your lesions. But they are expensive drugs not available in India, and what we use right now is rituximab, which is given 1 gram IV every 6th monthly. Okay, what are the side effects of rituximab? Acutely it can cause infusion reactions. And since it is an anti-CD20, there is a risk of tuberculosis reactivation, and hence we do a IGRA and TB testing prior to the treatment. Okay, so this is about the first group of drugs. Next, we have a drug called natalizumab, which is your alpha-4 beta-1 integrin inhibitor. What is the mechanism of action of natalizumab? The mechanism of action is that it inhibits the entry of lymphocytes to the blood-brain barrier. So isn't that something very interesting? It inhibits the entry of lymphocytes itself through the blood-brain barrier, right? So we know that it is because of autoimmunity. So MS pathogenesis is because of autoimmunity, but lymphocytes itself are not allowed to enter. So that is your natalizumab, and it is given 300 mg IV every monthly, right? The most important side effect is a neurological disorder that we call as progressive multifocal leukoencephalopathy or PML. PML is progressive multifocal leukoencephalopathy. which is characterized by severe cognitive dysfunction, and this occurs due to JC virus reactivation. So when you give drugs like natalizumab, what happens is there is a lot of immunosuppression and there can be JC virus reactivation, okay, which causes PML. You will have heard about this in your HIV classes. Fine. So that is natalizumab. Then we have the sphingosine 1-phosphate modulators. These also inhibit the egress of lymphocytes from the lymph nodes itself, right? So it in fact inhibits the egress of lymphocytes from the lymph nodes itself. So lymph node or spleen. That is your fingolimod, ozanimod, ponesimod. Okay, fingolimod, ozanimod and ponesimod. So fingolimod is the sphingosine 1-phosphate 1,3,5 modulator. Ozanimod acts on only 1 and 5. Okay, so the major advantage of this siponimod, fingolimod, ozanimod is that they can be given as an oral drug at a dose of 0.5 mg daily, and it decreases the further attack rates by altering the autoimmunity, right? So most important side effect of fingolimod is that it has a lot of cardiac conduction abnormalities which can occur with fingolimod, which is overcome by ozanimod, which does not have this cardiac side effects, right? So the major side effects are heart block, there can be reactivation of varicella zoster, increased risk of cryptococcal infections and macular edema. Increased risk of cryptococcal infections and macular edema. Ponesimod is used in cases which are refractory to fingolimod or ozanimod. You can use a newer drug which is ponesimod. Okay, so that is about your sphingosine 1-phosphate modifiers. Then other drugs which are useful, which are not commonly used, includes your dimethyl fumarate, which basically inhibits your breakdown of antioxidants, and it is associated with side effects such as acute liver failure and lymphopenia. Glatiramer basically binds to the MHC and displaces the myelin basic protein. We know that the CD8 cells basically act against this myelin basic protein which are presented by the MHC cells, right? So this binds to MHC and displaces this myelin basic protein, right? So that is a very interesting mechanism of action of glatiramer, and it also causes stimulation of your T suppressor cells, thereby modulating the immunity. And this is given as a 20 mg subcute dose. But these are moderately effective drugs in the management of MS. Then mitoxantrone, where is it used? It is used in rapidly progressive MS. Mitoxantrone is not used often because it causes a very dangerous side effect. It can cause leukemias, it can cause acute leukemias, right? But in rapidly progressive MS, mitoxantrone can be used. Then other drugs. What do you use for secondary progressive MS? Siponimod, ponesimod, ocrelizumab. Ocrelizumab is the only drug which has been FDA approved for primary progressive MS. The best drug available in the market today is ocrelizumab. What are the other drugs? IVIG, cyclophosphamide, azathioprine can be used, but they are not frequently used. Okay. So this is about the various drugs used in the management of multiple sclerosis. But management of multiple sclerosis does not end here. It also includes management of all the other symptoms which an MS patient can present with. So what are the other drugs that are used? An MS patient can present with ataxia. Yes, that can be quite a debilitating symptom. Hence, the drugs which are used in the management of that is clonazepam and primidone. MS patients can present with severe spasticity that prevents them from walking or even getting up and carrying out their activities of daily living. To improve the spasticity, we give muscle relaxants like baclofen. Okay? A new drug which is a potassium channel inhibitor which basically improves walking in MS. Improves walking in MS patients is called as your dalfampyridine. Dalfampyridine improves walking in MS patients, right? Then there can be more than 90% of the individuals having fatigue and they can have difficulties in sleeping, or they sleep excessively during the morning time. So to improve the alertness in the morning and to improve the sleep-wake cycle, you can give modafinil. Okay, you can give modafinil. Paroxysmal symptoms. The paroxysmal symptoms, as we had discussed, the best treatment option would be anticonvulsants. And bladder dysfunction, depending on whether this is detrusor hyperreflexia or detrusor muscle and sphincter dyssynergia, you can give tolterodine. Okay, fine. So this is about the various drugs which are used in the symptomatic management of multiple sclerosis depending upon what symptoms they are. Okay, lastly but not the least, we should be knowing about the different variants with which MS can present, right? So first variant is this, which is your little dangerous looking variant, where you have these highly tumefactive lesions. You have large tumefactive lesions which have a poor prognosis and they are rapidly progressive, and this is called as Ballow's concentric sclerosis, right? Then we have something called as acute MS, which is characterized by these huge plaques. Okay, it's characterized by these huge plaques and it is also rapidly progressive with a poor prognosis. Okay, fine. So with this, we have come to the end of our chapter on multiple sclerosis. We have understood what is MS, the pathogenesis, what are the different clinical features. We have learnt about the diagnostic criteria, CSF findings, and how the drugs modulate the immunity and which is used in the management of MS along with the side effects. Now we will move on to this group of disorders that we call as your Neuromyelitis Optica Spectrum Disorders, which is your NMO spectrum disorders and your MOG antibody related disorders. Okay, so what is the basic differences between your Neuromyelitis Optica or your NMO spectrum disorder and multiple sclerosis? So NMO spectrum disorder is also a demyelinating disorder. The basic immunological difference between your MS and your NMO spectrum disorder is that there are antibodies to aquaporin 4, right? So what is this aquaporin 4? So you can see that this is basically a oligodendrocyte, right? And this is the blood vessel forming the blood-brain barrier, and if you enlarge it, you have aquaporin 4 molecules which are basically present at the foot processes of the oligodendrocyte, and there are antibodies which are going and attacking this. Okay, so this is the basic pathophysiological difference between NMO spectrum disorders and MS. Okay, fine. So how are the clinical features different? In NMO, the females are affected more than males, and it affects the age group of approximately 40 years of age. MS is usually more common in the younger age group, and it causes bilateral severe optic neuritis. MS usually is heralded by unilateral optic neuritis, but here it is heralded by bilateral optic neuritis. Then, third most important characteristic feature is the presence of this LETM, which is longitudinally extensive transverse myelitis. Okay, so we have LETM or the longitudinally extensive transverse myelitis, where more than three segments of the spinal cord, contiguous segments of the spinal cord are involved. More than 3 contiguous segments of the spinal cord is involved, which is usually not seen in MS. Okay, fine. And also the presence of encephalopathy, and presence of area postrema syndrome. You've heard of area postrema in your basic anatomy classes, right? So this region is present in the medulla, and it is not surrounded by the blood-brain barrier, and hence it is more prone to immunologically mediated damage, where the area postrema is your vomiting center. It is your vomiting center. So damage to the area postrema can cause recurrent hiccups, recurrent vomiting. Okay, it can result in recurrent hiccups, recurrent vomiting. Unexplained hiccups can be a presenting feature of NMO spectrum disorders. Okay, and when you do your diagnosis, it shows CSF pleocytosis, more than 30% of polymorphonuclear cells, whereas in MS, what did we find? We found mononuclear cells. Here you have neutrophils. And the oligoclonal bands is found in less than 20% of the individuals with NMO spectrum disorders, right? So oligoclonal bands is not quite common because the immunopathogenesis itself is slightly different from MS. Okay, fine. So neuromyelitis optica, which was also called as Devick's disease, it was also called as Devick's disease, was a disease which was similar to MS, but it has certain different characteristics that we have just discussed. Okay, so the main thing or the crucial feature is the presence of antibodies to aquaporin 4. Fine. And it is characterized by LETMS, which is your longitudinally extensive transverse myelitis, area postrema syndrome, and CSF pleocytosis. Neutrophilic OCB bands are found in less than 20% of the individuals and causes bilateral optic neuritis. Okay, fine. So let us understand the diagnostic criteria for NMO spectrum disorders. Right, so the diagnostic criteria should be at least one core clinical characteristic and positive test of aquaporin IgG antibodies and exclusion of other diagnoses. Right, so what are the core clinical characteristics for the diagnosis of NMO spectrum disorders? It includes optic neuritis, which is bilateral and severe. Acute myelitis, it is longitudinally extensive transverse myelitis. Area postrema syndromes, episode of otherwise unexplained hiccups, nausea, vomiting. Understood that. Symptomatic narcolepsy or diencephalic clinical syndrome. That means what? Narcolepsy means sudden sleep attacks. This can be because of damage to the sleep centers in the hypothalamus. So there is sudden change from wakefulness to sleep without any reason. So this can be in fact a clinical manifestation of NMO spectrum disorder. Okay. Then acute diencephalic clinical syndrome, where the diencephalon can be involved. Right? Then symptomatic cerebral syndrome, which is nothing but your encephalopathy kind of features, can also be a core clinical characteristic of NMO spectrum disorder. So for the diagnosis of NMO spectrum, you need at least one core clinical. So for example, we had a patient where she had refractory hiccups. We never found a GI cause, and when we did the MRI, we found evidence of area postrema syndrome. So the presence of area postrema syndrome with aquaporin antibody positive, you directly diagnose them as NMO spectrum disorder. In cases where the aquaporin 4 is negative. So in cases where the aquaporin 4 is negative, how will you diagnose NMO spectrum? Two core clinical characteristics. And at least one clinical characteristics must be either acute neuritis or LETM or area postrema. There should be two core clinical characteristics and at least one of the clinical syndrome should have been an area postrema or LETM or optic neuritis, and it should show evidence of dissemination in space, right? And other diagnoses are not considered. Fine. So that is about your diagnosis for NMO spectrum disorder. Okay. Fine. Right. Now, what are the associated conditions with NMO spectrum? So, 40% of the patients with Neuromyelitis Optica can have SLE, Sjogren syndrome, vasculitis, myasthenia gravis, suggesting that you can have associations with other autoimmune disorders. Right? So, what is the treatment? We give rituximab 6 monthly. All the great drugs that we use, which are disease-modifying agents for MS, is not effective in NMO spectrum disorders. It's predominantly your anti-CD20 rituximab. Then eculizumab has been tried, which is your complement C5 inhibitor. Newer drugs, which is inebilizumab and satralizumab. The newer drugs which are being used in the management of NMO spectrum disorders is this. So, inebilizumab is B-cell depleter, satralizumab is interleukin-6 receptor inhibitor. Okay, so that is about your NMO spectrum disorder. Now, let us understand what is this MOGAD. MOGAD is MOG antibody disorder, where MOG stands for myelin oligodendrocyte glial protein. Okay, right? So, this disorder is more common in children and it is more frequent with relapses, right? And here also you have bilateral optic neuritis, but predominantly involving the anterior part of the optic tract, right? Anterior part. So, it is associated with papillitis. Whereas when it comes to NMO, it is usually the posterior part of the optic tract, which is here. These are the ones which are getting affected in your NMO spectrum disorder. Again, you have LETM symptoms, and very importantly, you can have conus lesions. So, the presence of demyelination in younger individuals with conus lesions, with relapses, anterior optic neuritis, papillitis, all of these are features of MOG antibody disorders. Okay, Here also the CSF oligoclonal band is less than 10%, right? It is found in less than 10% of the individuals. So CSF oligoclonal bands is not positive. So every time a patient presents with transverse myelitis, you suspect MS. If the workup is negative, you think of NMO-MOG, you send your blood or you send your serum levels NMO-MOG for the presence of antibodies, or you send your CSF NMO-MOG for the presence of antibodies. So the treatment for this includes steroids, IVIG and rituximab. So IVIG is useful in your MOGAD disease. Fine. So this is in brief about your NMO spectrum disorders and MOGAD disorders and how it is different from MS. Thank you.